I invite Dr. Sunil Chiruvilla. He has done MBBS from Bengaluru University and MD anesthesia in JJ Medical College, Belgaum, in 2005. So he worked as a professor in Kurnool Medical College, presently working as professor and HOD in Government Medical College, Kadapa, Andhra Pradesh.
Okay.
He is a postgraduate teacher and MD and DNB examiner and NMC assessor since 10 years. He has publication in various national and international journals. He is a regular speaker in State, South Zone and National Conference, presented in SARC International Conference. His area of interest is obstetric anesthesia, obstetric care, critical care, acute pain management, and airway management, and ambulatory surgery. Over to research.
A warm and pleasant morning to the esteemed chairpersons in the gathering. At the outset, I bring greetings from my institute and from my home state and extend my best wishes to the organizers. High-risk surgical patients are bound to surface in anesthesia practice. We cannot deny that, and we have to face it. And one of the most demanding situations can be a post-hypophysectomy patient posted for surgery. We all know that pituitary is associated with vital endocrinological hormones, of which they can obviously dictate the perioperative course and outcome. An outline of my presentation today: obviously, post-hypophysectomy leads to panhypopituitarism. So what are the clinical manifestations of panhypopituitarism of interest from anesthesia perspective? The guidelines of hormone replacement therapy. The urgency of surgery can definitely impact the perioperative course and ultimately the perioperative management. As I mentioned earlier, hypophysectomy can ultimately lead to panhypopituitarism. So we all know that pituitary is associated with various endocrinological hormones, but what is striking is, number one, the ACTH deficiency can lead to adrenal insufficiency, and number two, TSH deficiency can lead to hypothyroidism, and in a minor percentage of patients, ADH deficiency can lead to diabetes insipidus. We have to be aware of these situations and deal accordingly if and when the situation arises. So the clinical manifestations can be quite diverse across a spectrum, but we are not definitely interested in hypogonadism or amenorrhea, but I have listed a few clinical manifestations on the sidelines which are of interest from our perspective, like anxiety, bradycardia, hypotension, depression, tachycardia, dyslipidemia, metabolic syndrome, and to make note of is osteoporosis from our clinical scenario. Because there is an imbalance between bone resorption and bone formation, this can seriously impact the present clinical scenario of post-hypophysectomy patient posted for upper limb fracture surgery. So obviously, these set of patients will be under the direct supervision of endocrinologist. But there can be issues of under replacement or over replacement, which we have to deal with during the perioperative course. And there are guidelines are in place for hormone replacement therapy that we did not bother. But what is interesting and most striking from our point of view is we have to make sure or ensure that adrenal insufficiency is conclusively excluded before we initiate LT4 therapy, as this can unmask the sublime adrenal insufficiency because it hastens the metabolism of cortisol. This we should make note and be aware of. Obviously, any surgery is impacted by its urgency, more so these high-risk cases. So urgency of surgeries can definitely impact the perioperative course and outcome. But from our clinical scenario of post-hypophysectomy patient posted for open fracture surgery, what is more important is, apart from open fractures without a vascular compromise, which has to be attended within 6 hours, all other fractures can be scheduled with a prior endocrinological consultation, and we have adequate time to optimize the patient. So this can seriously impact the perioperative outcome. So we have adequate time to optimize the patient in our clinical scenario. Moving on to the perioperative management, the first is preoperative management. The obvious concerns are obesity, as mentioned earlier, hypothyroidism, adrenal insufficiency, and also some percentage of patients will have diabetes insipidus. These set of patients are prone to extreme metabolic and hemodynamic instability during the perioperative course. But what is important from our point of view is we have to make sure or ensure that the hormonal medications are administered until the day of surgery. This is very vital, and this should be taken care of. So from our point of view, we need to understand and manage, because these set of patients will obviously be on steroids. This cannot be denied. So they are very prone for an acute emergent condition called Addisonian crisis. So what we should be understanding is we have to understand and manage the steroid cover perioperatively, because most of the patients will be on prednisolone, oral prednisolone. So during crisis, we need to move on to the parenteral route of steroids. So we need to understand that 5 mg of prednisolone is equivalent to almost 20 mg of hydrocortisone and almost 0.75 to 0.75 mg of dexamethasone. This is very vital. Moving on to the intraoperative management, definitely we have an option of general anesthesia if in case the patient is unwilling for regional anesthesia, or there are obvious contraindications for regional anesthesia. So general anesthesia is always an option. We have in general anesthesia, again, the conventional and TIVA. It all depends on the preference of the anesthetist. But the point worth remembering is the anesthetic agents should be titrated to effect, because these set of patients are very sensitive to anesthetic agents. And the point is, all the agents which are in regular use, like propofol, CO, and DES, are safe to use. There is some low-quality evidence supporting it, but we have to ensure that we use only short-acting agents. The concerns during the intraoperative period are definitely there will be a challenging airway. They are prone for OSA, and they are also prone for water intoxication and hypoglycemia, which we have to treat promptly and swiftly. Again, in intraoperative management, apart from routine monitoring, we need to focus on the temperature monitoring, as they are prone for perioperative hypothermia. And also, we need to focus on invasive arterial blood pressure monitoring, because there can be extreme hemodynamic instability. So we need to treat hypertension with vasopressors, and also adrenocortical insufficiency has to be addressed with intravenous hydrocortisone, glucose, and IV fluids. Also, we should be aware of the depressed response to hypoxia and hypercapnia, because these can seriously impact the perioperative course, and these are candidates for perioperative hypothermia. So we should make all necessary arrangements to prevent hypothermia. And also, there is a possibility of a distinct possibility of delayed emergence from anesthesia, which we have to be prepared by pushing the patients for elective mechanical ventilation. So definitely, regional anesthesia is a beautiful option. We all anesthetists are fond of regional anesthesia if and when it is applicable. So what about regional anesthesia from our clinical scenario? Means post-hypophysectomy patients posted for upper limb fracture surgery. Again, regional anesthesia depends on the type of fracture, the invasiveness of the surgery, the position of the patient, and also the comorbid conditions, the use of anticoagulants, the application of tourniquet. So a variety of factors can influence regional anesthesia, but definitely if and when applicable, we all vouch for regional anesthesia, and that is the case because we all know that regional anesthesia offers a better stress management when compared to general anesthesia. So the most frequently occurring fractures of the upper limb are the fracture both bones, followed by fracture humerus. So we should be wary of this extreme emergent catastrophic condition, Addisonian crisis, which can unfold during the perioperative phase, more so in the intraop and postoperative phase. So what we can do from this point of view is we need to measure cortisol periodically, and if suspected, we need to act promptly by administering 50 to 100 mg of hydrocortisone. This is very vital. As I mentioned earlier, regional anesthesia is preferred because we all know that regional anesthesia offers better hemodynamic stability, better management of stress response, which is very vital in this case. And regional anesthesia, with the arrival of ultrasound, ultrasound has almost become inevitable for management of high-risk cases. It is an integral part of anesthesia armamentarium, and we are very confident in dealing with high-risk cases if ultrasound is with us. So obviously, again, it all depends. The regional anesthesia, as mentioned earlier, it all depends on the site of fracture, the application of tourniquet, the use of anticoagulants for that patient, comorbids, the position of the patient. All these should be taken into consideration while we plan for regional anesthesia. So what are the options of regional anesthesia for upper limb fracture surgery? Again, this is subject to the type of fracture, the invasiveness of the surgery, the surgical site, the application of tourniquet, the patient's preferences, and the patient's choices. All these come into play when we decide upon regional anesthesia, but if and when the patient is willing, and our first mode of anesthesia approach should be real anesthesia because there is ample evidence to support it. And usually, we all know about the traditional approaches, USG interscalene, USG supraclavicular, infraclavicular, axillary, and forearm blocks. And we always have this beautiful option of intravenous regional anesthesia. And what are the newer approaches? Newer approaches being USG superior trunk block, subomohyoid anterior suprascapular block, raptor block, the costoclavicular block. These are new approaches which keep on coming, and we can expect some more approaches in near future. So it's always very, with ultrasound, it's always very promising for the patient and for the anesthetist as well. So what is the beauty of ultrasound? The ultrasound, there is high quality evidence which supports that ultrasound, there is faster onset, and there is definite decrease in complications, and there is almost near 100% success rate because this is supported with the fact that with ultrasound, as displayed here, we can real-time pick up all the anatomical variations, and we can plan for a separate plan and act accordingly. So this can invariably increase the success rate with ultrasound. So ultrasound is a very almost an integral part of management of all the high-risk cases. Almost it is inevitable for the management of high-risk cases. The widespread use of adjuvants and the use of perineural catheters to augment analgesia and anesthesia, and also increased safety during the performance of regional anesthesia by application of injection pressure monitoring, the triple guidance, and enhanced comfort for the patient during the course of regional anesthesia by offering sedation. All these have profoundly improved the safety and comfort of regional anesthesia and drastically reduced the complications. So to conclude, post-hypophysectomy patients posted for surgery are prone to extreme hemodynamic instability and metabolic instability, specifically during the perioperative period. And obviously, general anesthesia, which requires even more intense monitoring and vigilance, can be disastrous with increased morbidity and mortality. Regional anesthesia, if applicable, mitigates many of these issues and come to the rescue with ultrasound, with its increasing outreach and available ever-increasing expertise. It has revolutionized acute pain management and regional anesthesia practice. And eventually, these set of patients require intense monitoring with a close coordinated effort between endocrinologist, surgeon, and anesthetist. With this, I conclude my session and thank the organizers for this kind invite.